Hello everyone. So we are starting with musculoskeletal disorders, chapter 28 of the illustrated textbook of pediatrics. He features musculoskeletal disorders in children, physical assessment with pre-GALs and pre-REMS, pre-GALs, pediatric gait, arms and leg spine, and pediatric regional examinations of musculoskeletal system. Many but not all concerns of parents about their children's posture are variation of normal alignment between skeleton. Early management of talipes, equinovirus, he usually avoids the need for surgery. NIP has a wide differential diagnosis. Juvenile GIA is the most common cause of chronic arthritis. Assessment of the musculoskeletal system district as it include the PGAL assessment, which was in chapter 2, identify and localize musculoskeletal problem. Any suggestion of musculoskeletal problem should be followed by more detailed UMs. Variation of normal observations are common and may be noticed by parents or on routine developmental surveillance. Most resolve without any treatment, but if severe, progressive, painful, functionally limiting, or asymmetrical, they should be referred for a specialist opinion. Leg genome and not least genome welcome. Leg alignment in young children may initially include a degree of bowing of the tibia, causing the knees to be wide apart. Genome best observed while the child is standing with the feet together. There are pathological causes of bowlies, which include nutritional rickets, check for the presence of other clinical features, other metabolic bone diseases, and skeletal dysplasia such as achondroplasia. Severe, progressive, and often unilateral bowlies. Bowlies is a feature of blount disease and sometimes tibia vera, uncommon condition in black African ethnicity and obesity as respected. Radiographs are characteristic with leaking of proximal medial tibial epiphysis. Genovalgum is when the feet are wide apart and standing with the knees held together. Knockings. Physiological genovalgum is the commonest cause, and maximum valgus is reached around 5 years and resolves spontaneously. An intermalleolar distance of greater than 8 centimeters is a pathological cause such as post-trauma, fracture of both plates, or metabolic bone disorders. Flat feet, best plan is toddlers learning to walk usually have flat foot due to flatness of the medial longitudinal arch. The presence of a fat pad which disappears as a child gets older, and arch can usually be demonstrated by standing on tiptoe or by passively extending the big toe. Marked flat feet are common in hypermobility. A fixed flat foot, with or without pain, presenting in older children with absence of an arch on tiptoeing may indicate an associated tendo-Achilles contracture, tarsal coagulation, or inflammatory arthropathy. And referred to pediatric rheumatology or pediatric orthopedic surgeon is indicated. Painful mobile flat feet are often held by footwear advice, and occasionally an arch support may be useful. In towing, there are three main causes of in towing: metatarsus adductus, an adduction deformity of a highly mobile forefoot resulting in a kidney bean shape foot. So this is bow legs, permanent toddlers, and not knees and best fairness, showing the flat feet of toddlers and medial lungs should not appear on standing on tiptoe. Metatarsus adductus, internal tibial torsion, and femoral anteversion. Typical features of in-toeing. Metatarsus occurs in infants, passively correctable heel. This is metatarsus adductus. Heel is held in normal position. No treatment required unless it persists beyond 5 years of age. Symptomatic. Internal tibial torsion may be associated with growing of tibia subcorrects within about 5 years. Everything is almost 4 to 5 years of age. Femoral anteversion presents in childhood, usually subcorrects by 8 years of age, may be associated with hypermobility of the joints. Children sit in the field with the hips fully internally rotated. That is called the W sitting. Most do not require treatment, but femoral osteostomy may be required for persistent anteversion. Internal tibial torsion at the lower leg when the tibia is laterally rotated less than normal in relation to femur when standing. The feet point inwards while the patella points straight or outwards. Persistent inversion of the femoral neck at the hip when the femoral neck is twisted forward more than normal when standing. The patella points. Clinical features are described: toe walking. Common with young children may become persistent usually from habit. The child can walk normally on request. Habitual toe walking needs to be distinguished from cerebral palsy, tightness of the Achilles tendons, or inflammatory arthritis in the foot or ankle. In older boy, Duchenne muscular dystrophy should be excluded. Abnormal posture, summary variations of musculoskeletal normality and differential diagnosis. Bow legs, normal age range is 1 to 3 years, dog plays 2 to 7 years, flat foot is 1 to 2 years, intoing is 1 to 2 years, into working is 1 to 3 years. Differential diagnosis to consider in bow legs is rickets, osteogenesis imperfecta, and Blount's disease. Knock knees 2 to 7 years, JIA, flat foot 1 to 2 years, hypermobility, congenital toxic fusion, in towing is 1 to 2 years, tibial torsion, femoral anti-version. Toe walking is 1 to 3 years, spastic dysplasia, muscle dystrophy, JIA, mucopolysaccharidosis. And abnormal posture, telebes, minor club foot, positional, telepes from intrauterine compression is common. The foot is of normal size, the deformity is mild and can be corrected to neutral position with passive manipulation. Often the baby's intrauterine position can be recreated. If the positional deformity is marked, pains can be shown passive exercise by the physiotherapist. Rhinovirus is a complex abnormality. The entire foot is inverted and supinated, and forefoot is adducted and the heel is rotated in plantar flexion. The affected foot is shorter and the calf muscle is thinner. The normal position of the foot is fixed, cannot be corrected completely, and is often bilateral. The birth prevalence is 1 per 1,000 live births. Effects predominantly mean 2:1 can be familiar but is usually idiopathic. However, it may also be secondary to oligohydramnios during pregnancy, a feature of malformation syndrome or of a neuromuscular disorder such as Panem bifida. This is association with DDH, which is development dysplasia of the hip. And treatment is started promptly with plaster casting and bracing, one steady method, which may be required for many months, results in successful outcome with a minority requiring corrective surgery. It changes us where this is the equinovirus. This thin calf muscles you rotate inwards, whereas an implanted flexion equinus. An entire foot inverted and supinated forefoot is adducted and short foot. And this is the picture. These were the abnormalities where 5 abnormalities, equinus, inversion, dorsiflexion. Sorry, that was Telpis equinoris. This one is Telpis calcaneovalgus. Eversion and dorsiflexion. Regarding Telpis equinoris, needs to be differentiated positional Telpis. Check for neuromuscular disorders or spinal lesion or for DDH. Early plaster casting bracing conservative method usually avoids needs for surgery and has been adopted worldwide. Telpis equinoris need to be differentiated from the rear congenital vertical talus where the foot is stiff and off a bottom in shape. Many of the diseases are neuromuscular and genetic disorder diagnosis can be confirmed when X-ray surgery is usually required. Telpis can carry virus that was effect and inverted. It usually results from intrauterine molding and self-corrects. Passive foot exercises are sometimes advised. There is an association with DDH. Tarsal coalition. This results from lack of segmentation between one or more bones of the foot and coalitions, fibers or cartilaginous abnormal connections becomes symptomatic as they begin to ossify. The foot becomes progressively more rigid with limited foot motion. The feet often become more symptomatic during the pre-adolescent years. Radiograph may be normal to coalition have not yet ossified. Corrective surgery may be required, but treatment is not indicated if coalition is asymptomatic. Pescivis is abnormality elevated longitudinal arch when it presents in longitudinal, it is often associated with neuromuscular disorder, Friedreich ataxia, and type 1 hereditary motor sensory neuropathy. Peroneal muscular atrophy. Treatment is required if the foot becomes stiff and painful. DDH is spectrum of disorders ranging from dysplasia to subluxation through to frank dislocation of the hip. Early detection is important as it usually responds to conservative treatment. Late diagnosis is usually associated with hip dysplasia, which requires complex treatment, often including surgery. It is uncommon for infants and young children with DDH to have any pain or other limitation. Neonatal screening is performed as part of the routine neonatal and infant physical examination. Checking if the hips can be dislocated posteriorly out of the acetabular Barlow maneuver and can be relooked at Ortolani and Barlow maneuver. Back into the acetabulum on abduction, first checking can be dislocated posteriorly out. Barlow and Ortolani is Moving back into on abduction, when the sensation relocation is distinct and usually described as a clunk. These tests are repeated as routine night surveillance at 8 weeks of age. Therefore, thereafter, presentation of the condition is usually with a limp and abnormal gait. It may be identified for asymmetry of the skin folds around the hip, limited abduction of the hip, or shortening of the affected leg in later cases, but this may not be apparent if it condition is bilateral. Walking shoulder-related DDH, a treadle with pelvic test when standing on the affected leg, the pelvic drops on the opposite side due to weakness of the hip abduction may be positive. On neonatal screening, abnormality of the hip is detected in about 6 to 10 per thousand live births. Most resolve spontaneously. True birth prevalence of DDH is about 1.3 per thousand live births. Clinic and neonatal screening misses some cases. This may be because of inexperience of the examiner, but in some, it is not possible to clinically detect dislocation at this stage, where there is only a mildly shallow settlement. If developmental dysplasia of the hip is suspected on clinical examination, specialist orthopedic surgeon should be obtained. An ultrasound indicative there is clinical suspicion on the hip sensibility, inconclusive hip examination in the presence of risk factors, family history of DDH, reach presentation at more than or equal to 34 weeks gestation is the main technique to assess the morphology and stability of the hip joint in an infant. In some countries, routine ultrasound screening of all the babies is performed, but it is not recommended in the UK as it is expensive and has a high rate of false positives. The main goal of treatment is to maintain reduction of the hip is to allow development of the femoral head and the acetabulum. If indicated, infant may be placed in the splint or harness to keep the hip flexed and abducted for several months. Progress is monitored by repeat ultrasound and excess splinting must be done expertly as necrosis of femoral head is a potential complication. In most instances, a satisfactory response is obtained. Surgery is required if conservative may fail. Scoliosis is a lethal curvature in the frontal plane of the spine. The structural scoliosis is a rotation of vertebral bodies which causes a prominence in the back forward asymmetry. In most cases, changes are mild, pain-free, and primary cosmetic problem. However, in severe cases, spinal curvature can lead to cardiopulmonary compromise. Clinical evaluation of scoliosis should include the underlying cause, magnitude of the curvature, causes of scoliosis, and determine the risk of progression. Causes of scoliosis, idiopathic, the most common early, either early or less than 5 or more of a late onset, mainly girls 10 to 14 years of age during the pubertal growth. Spurt congenital from a congenital structural defect of spine, hemivertebral, spinal bifida syndromes, vertebral, anal, rectal, cardiac, tracheoesophageal, renal, limb, vectoral anomalies association, secondary related to other disorders such as neuromuscular imbalance, cerebral palsy, muscular dystrophy, disorders of bone such as neurofibromatosis, or of connective tissue such as Marfan syndrome, or leg length discrepancy due to arthritis of one knee in juvenile GIA, juvenile idiopathic arthritis. Examination should start with inspection of the child's back while standing up straight. In mild scoliosis, there may be irregular skin creases and difference in shoulder height. The scoliosis can be identified examining the child's back when bent forward. If the scoliosis displays of forward bending, it is postural, although leg length should be checked. My scoliosis will resolve spontaneously or progresses minimally if most with the severity of the progression and the curvature of the spine determined by X-ray. Severe cases are managed in specialist spinal centers where the place of non-medical treatment such as bracing will be considered, with surgery indicated only if severe and therapy is coexisting pathologies such as neuromuscular or respiratory disease. This is scoliosis, which is shown by the rotation on bending forward. Torticollis is the most common cause of torticollis. Why neck in infants is a sternomastoid tumor, congenital muscular torticollis. They occur in the first 2 weeks of life, present with a mobile, non-adherent nodule which can be felt within the body of congenital mastoid. There may be restriction of head turning, tilting of the head. The condition usually resolves in 2 to 6 months. Passive stretching is advised, but is efficacy unproven. The most common acquired cause of torticollis presenting later in childhood is injury and inflammation of the sternocleidomastoid. It repeats muscle groups or acute infections of the ear, nose, throat. Other causes include spinal tumors such as osteoid atlantoaxial subluxation, posterior fossa tumor. The painful limb, knee, back, growing pains, episodes of generalized pain in the lower limbs referred to as growing pains or nocturnal idiopathic pain are common in preschool and school-age children. The pain often makes the child from sleep and settles with massage or comforting. There is no consensus for its definition, but the following clinical features are commonly seen, often referred to as rules of growing pains. Age 3 to 12 years, bilateral, symmetrical, mainly lower limbs, are not limited to joints. Pain never present at the start of day after waking. Physical activities are not limited. No limb physical examination normal, including BGALs, with the exception of joint hypermobility in some joints otherwise well. If the presentation does not fit the rules, then further assessment necessary in addition to massage, heat, or simple analgesia. These are measurement of leg length discrepancy between the anterior superior spine and medial malleolus. This is hypermobility syndrome showing ability of a mother and two of her children to hyper extend the thumb onto the forearm. Supernergies such as paracetamol will be helpful. Some explanation and reassurance are required as well as advice and supportive footwear. Trainer shoes require shoelaces properly fastened. Hypermobility. Other children adolescents with hypermobility may complain of musculoskeletal pain, often worse after exercise. Joint swelling is usually absent or is transient. Hypermobility may be generalized or limited to peripheral joints such as hands and feet. Signs may include symmetrical hyperextension of the thumbs and fingers that can be hyperextended onto the forearms. Elbows and knees can be hyperextended beyond 10 degrees and palms can be placed flat on the floor with knees straight. In addition, flat feet may be seen with normal arches on tiptoe, which are overpronated secondary to ankle hypermobility. While mild degrees of hypermobility are a normal finding in younger children, and many children with hypermobility are asymptomatic and find being very flexible an advantage in dancing, gymnastics. Some children, young people, and adults experience recurrent mechanical joint muscle pain, which is often activity related. Treatment should be individualized depending on the symptoms. This may include specialist assessment with advice about footwear, exercising, occasionally orthotics. Hypermobilities also feature some chromosomal syndromes, Down syndrome, and some inherited collision disorders, Marfan Ehlers-Danlos syndrome, complex regional pain syndrome. The most traumatic suicidal pain is that encountered in complex regional pains and CRPs, which is a presentation of persistent unexplained physical symptoms, child mental health. It is characterized by severe pain that is out of proportion to the extreme physical findings and is often accompanied by one or more autonomic signs. In contrast to adults, an initial physical injury may be absent is more common in adults and females. Localized forms often present with foot and ankle involvement, typically unilateral, and the pain can be extremely incapacitating, often triggered by minor trauma without a clear precipitant. Presentation in the clinic may be in a wheelchair. In addition to severe pain, there may be hyperesthesia, increased sensitivity to stimuli, allodynia, pain from a stimulus that does not normally produce pain, and the affected part, often a foot or hand, may be cool to touch, be swollen, mottled, have infection with minimal, if any, active movement, and bizarre posturing is not uncommon. Typically, with distraction, the normal range of passive movement is impossible. Diffuse forms are characterized by severe, widespread pain with disturbed sleep patterns, feeling exhausted during the day with extreme tenderness over soft tissues, the characteristic tender points that are found in adults with fibromyalgia may be absent or fewer in number in children. The child or adolescent with complex regional pain is otherwise well in physical examination, otherwise normal. No laboratory or imaging studies can confirm or exclude disorder. The etiology is unknown. Mind and body link and chronic pain is considered in chapter 24. Child and adolescent mental health, multidisciplinary rehabilitation regimen is required predominantly physical therapy based, either community or inpatient. The goal of treatment is to restore function and relieve pain, along with assisting children to develop skills to cope with any residual pain. Acute onset limb pain of acute onset has a number of causes. Trauma is the most common and usually accidental from sport injuries or fall with occasionally non-accidental osteomyelitis. Wound tumors separations are uncommon but need urgent treatment. Osteomyelitis is the infection of metaphyseal bones. The most common sites are distal femur and proximal tibia, but any bone may be affected. It is usually due to hematogenous spread of the pathogen, but may arise by direct spread from an infected wound. The skin is swollen directly over the affected site. When the joint capsule is inserted distal to the place, adjacent the hip, osteomyelitis may spread to cause septic arthritis. Most infections caused by Staph aureus, but other pathogens, strep, Haemophilus influenza, and Haemophilus influenza are not uncommon due to routine vaccination, but some serious types of Streptococcus pneumonia are not included in the pneumococcal vaccine. Pneumococcal conjugate vaccine may be a pathogen. Risk factor. Risk factors. Sorry. Risk factors include sickle cell anemia, immunodeficiency. In sickle cell anemia, there is an increased risk of staphylococcus salmonella osteomyelitis, tuberculosis, or non-tuberculous mycobacteria, uncommon in UK, but need to be considered, especially in children with immunodeficiency. Presentation. Initial symptoms are often non-spectral, such as low-grade pyrexia or malaise. Once the infection becomes established in the bone, it presents with a mildly painful, immobile limb, pseudoparesis. In a child with an acute febrile illness, there may be localized findings of bone inflammation, such as tenderness, bone swelling. Moving the affected limb usually causes severe pain. There may be sterile fusion of an adjacent joint. In infants, presentation may be more insidious, and bone infection can spread to the adjacent soft tissues, and the limb may be swollen or have reduced movement. If the infection affects the vertebral bodies, children present with dull, constant back pain and tenderness with percussion over the affected vertebrae. Investigation blood cultures should always be taken, although they are not always positive. Viable count and erythrocyte segmentation rate and C-reactive arrays. X-ray may be initially normal, other than showing soft tissue, and it takes 7 to 10 days for periosteal reaction from new bone formation or edema to become visible. Magnetic MRI can detect inflammation earlier than plain radiographs and allows differential of bone from soft tissue infection. The X-ray changes of chronic osteomyelitis are shown. Lytic cirrhotic lesions are suspected for chronic infection. Treatment with parenteral antibiotics based on the most likely pathogen and the child's age is indicated. Subsequently adjusted according to the antimicrobial sensitivity. Aspiration surgical decompression of the subperiosteal space may be performed representationally typical in immunodeficient children. Clinical improvement should occur in a few days. Introduction as acute phase reactant can be used to monitor progress and change to oral antibiotics. Failure to improve suggests a complication such as periosteal abscess or antimicrobial resistance and surgical drainage can may be required. The affected limb is initially rested in a spleen, especially when bone involvement is extensive to prevent pathological features. Some users present with fever, painful immobile limb, swelling and extreme tenderness, especially on the moving the limb. Blood culture is usually positive but may be negative. Parenteral antibiotics may be given immediately. Surgical drainage is indicative and responsive to antibiotic therapy. This is possible spread of osteomyelitis in children. The epiphyseal growth plane limits the spread. Metaphyseal infection infects the maturation growth plane infection can spread directly to cause joint destruction and arrested growth. This is an MRI, which is osteomyelitis, a metaphyseal proximal humerus showing abnormal metaphysis and a subperiosteal extraosseous membrane. Chronic osteomyelitis showing periosteal reaction along the lateral shaft of the tibia and multiple hypodensilia within the metaphyseal regions. Malignant Ezekiel lymphocytic leukemia may present with bone pain in children, sometimes family at night, even frank arthritis. Neuroblastoma, usually in younger children, may present with systemic arthritis or bone pain for metastasis, which may be different. Localized bone tumor, malignant bone tumors, osteogenic sarcoma, even tumors are rare. They present with pain or swelling, or occasionally with pathological fracture. Radiograph or joint should include the long bone above and below, especially with knee and distal femur and proximal tibia are the most common sites for malignant bone tumors. Further are in chapter 22, osteoarthritis benign tumor affecting adolescents, especially boys, usually involved in the femur tibia spine. The pain is progressive and typically worse at night and relieved by NSA therapy. There may be localized tenderness soft tissue swelling, limb joint effusion, and if sighted, near joint scoliosis if in the spine. X-ray is usually diagnosed with a sharply demarcated radiolucinitis of osteoid tissues surrounded by cerebral bone. MRI CT scan may be required to confirm diagnosis when indicated if the X-ray is normal. Treatment of the symptomatic lesion is by surgical removal and carries a good prognosis. Painful knee. When accessing painful knee, hip must always be examined as hip pain is often affected to the knee. Musculoskeletal disease, this is osteochondritis of the patellar tendon insertion as a typical tuberosity in the knee after affecting adolescent males and causing by repetitive strain from overuse inactivity. Activities such as football, basketball, presentation is usually with anterior knee pain after exercise, localized tenderness, and sometimes swelling over the typical tuberosity. There is often hamstring tightness. It is bilateral in 25 to 50% cases. This is a self-limiting condition, usually resolves the occasion of the growth plate, mind, analgesics, reduce impact, activity, and physiotherapy to strengthen the quadriceps muscles may be helpful. Chondromalacia patella, there is softening of the articular cartilage of the patella. It most often affects adolescent females, causing pain when the patella is tightly opposed to the femoral condyles, as in standing up from sitting or on walking upstairs. It is often associated with hypermobility and flat feet, suggesting a biomechanical component to its etiology. Treatment is with physiotherapy for quadriceps muscles strengthening. Osteochondritis, second segmental avascular necrosis or subchondral specific pain in the knee, elbow, or ankle may reverse physical activity, often physical active adolescence. The knee may lock or give way. Pain is caused by separation of segments of subchondral bone and articular cartilage from the underlying bone following avascular necrosis. Pain radiographs should be performed. Complete separation of articular fragments may result in loose body formation, but radiographs will be normal with small lesion. Treatment is initial restriction of activities and immobilization followed by physiotherapy. Surgical treatment recommended for a loose foreign body or if unresponsive to medically. Subluxation, dislocation of patella. Subluxation of patella refers to excessive weight movements of the patella and produces a feeling of instability or giving way of pain. It is often associated with generalized hypermobility and high riding patella. Patella apprehension tests apprehension and contraction practices when the examiner pushes the patella laterally is usually positive. Really, distribution of patella can occur usually laterally, suddenly, and with square pain reduction occurs spontaneously or in gentle extension of knee treatment with physiotherapy focusing on quadriceps exercises and orthotics to address biomechanical changes in muscle alignment. Sometimes surgery is required to realign the pull of the quadriceps on the patellar tendon. Injuries, contact sports characteristically result in acute injuries to the knee, while non-contact sports sustained activity tend to result in chronic injury and overuse syndromes. Sporting injuries to the menisci and ligaments are common in adolescents. MRI scans are helpful to determine the extent of damage. Management is usually conservative in infants and young children. Similar injuries are more likely to result in fractures as the ligaments are relatively stronger than their bones. Back pain is a symptom of concern in a very young and pre-adolescent ages, as in contrast to adults, and cause can often be identified. The younger the children, the more likely there will be significant pathology. Red flag clinical features are listed. Mechanical causes. There may be muscle spasms, soft tissue pain from injury, often sport-related or from poor posture or abnormal loading, such as carrying heavy school bags or muscular tumors. Benign malignant spine is a common site for osteoid It may also be site in frontal tumors or metastasis. Vertebral osteomyelitis or discitis. There is a localized annular pain usually normal as not illness. For the imaging, MRI is often required. Treatment is with IV antibiotics, spinal cord inner root entrapment from tumor or collapse in IV disc, often associated trauma or heavy lifting. Uh, Sherman disease is an osteochondrosis affecting the thoracolumbar spine, in which there is wedging of some bodies from the posterior part of the vertebra growing more than the interior. Presentation is in early adolescence, fluid, subacute back pain made worse with activity. Those with kyphosis have a sharp angulation of the spine on bending over. Diagnosis is usually made on these are red flags from the feature of back and younger, usually some pathology most likely less than 5 years. And fever and malaise with osteomyelitis, night waking, persistent pain, osteoarthritis, or intermittently extracellular tumors, painful scoliosis, infection, or malignancy, focal neurological signs, including asymmetry, flexors, weakness, valvular infection, nerve bruise, spinal cord compression, tendon cord, morning stiffness, inflammatory arthritis. Acute trauma and pain relation to buttocks, intervertebral disc herniation associated with loss, systemic malaise is malignancy. And the extreme many cases, radiographic changes are coincidentally finding the patient asymptomatic. Spondyle, spondylolysis and spondylolysis, stress fracture of the pars interarticularis of the vertebra, increased risk with activities that require repetitive flexion, extension, or acrosection of spine, such as in gymnastics or bowlers and cricket. If bilateral pain results in spondylolisthesis, forward slip of the vertebral body, and potential for a nerve compression. Consider in adolescents with low back pain, exacerbated hyperextension of the spine, and localized tenderness may be been on X-ray. Often further imaging is required. Chronic pain syndrome diagnosed with no physical cause is found, may be exacerbated by psychological stress, abnormal pathologies. Abdominal pathologies such as pancreatitis can present with back pain, usually accompanying abdominal symptoms and signs. Limb can be divided into acute painful limb and chronic or intermittent limb pain may or may not be presenting feature and by age. Transient synovitis, irritable hip, this is the most common cause of acute hip pain in children. It occurs in children 2 to 12 years of old. It often follows accompanied by viral infection. Presentation is with sudden onset of pain in hip or limb. There is no pain at rest, but there is a decreased range of movement, particularly interrogation. Interrogation. Pain may be referred to the knee. The child is afebrile, has a mild fever, and does not appear ill. It can be difficult to differentiate transient synovitis from early septic arthritis of the joint. And if there is suspicion of septic arthritis, joint aspiration and blood cultures are mandatory. The kosher criteria are a useful tool to differentiate septic arthritis from the transient arthritis in a child with painful radiological imaging may identify synovitis and exclude other causes, but is usually not required. Management of transient synovitis is with bed rest and really skin traction. It is usually improves within a few days. Plegaportis disease is an avascular necrosis of capital femoral epiphysis of the femoral head due to interruption of blood supply, followed by revascularization and reossification over 18 to 36 months. It mainly affects boys with female ratio 4:1 of 5 to 10 years of age and associated with obesity. Presentation in serious with onset of labor, hip or knee pain. Condition may initially be mistaken for transient synovitis, bilateral 10 to 20% of suspected X-ray on both hips, including fog views, should be requested, may be normal early in the disease. MRI misses will make a diagnosis in the later stages of the disease. X-ray should show increased density in the femoral head, which subsequently become fragmented and can leave residual deformity. Treatment involves physiotherapy initially to optimize the range of movement. Sometimes surgery is required, and most severe prognosis is good, particularly in those below 6 years of age with less than half the epiphysis involved. In older children, on with more extensive involvement of the epiphysis, deformity of the femoral head, and metaphysial physical. Wait. I think we can do all of the metaphysical damage are more likely with potential for subsequent degenerative arthritis in adult life. And this we will do in next. Thank you very much.